Last week, I saw a patient who had been on a low FODMAP diet for 12 years, self-prescribed, no reintroduction, no professional guidance. Every time he tried to eat normally, his symptoms came back, and he interpreted that as proof he needed to stay on it forever. What he didn't know was that the diet itself had become part of the problem. Now, before I go any further, I want to be really clear about something. This episode is not about vilifying any particular diet. Low FODMAP, keto, and carnivore all have legitimate therapeutic applications in the right context, for the right duration, and under professional guidance. What I'm talking about today is something very different: self-prescription, indefinite restriction, and the complete absence of root cause investigation. And given my extensive experience in working with constipation and gut health, I want to talk specifically about what these diets do to the bowel, because this part of the conversation is simply not happening enough. So let's start with low FODMAP, because this is the one I encounter most often in clinical practice and the one that is most widely misunderstood. The low FODMAP diet was developed by Monash University researchers, initially led by Professor Peter Gibson and Dr. Sue Shepherd, as a structured, evidence-based elimination and reintroduction protocol for managing IBS symptoms. It was never designed as a permanent way of eating. Monash is unambiguous about this. The strict elimination phase is designed to be followed for just 2 to 6 weeks until symptoms resolve, after which gentle reintroductions under qualified practitioner guidance are essential. The full process actually has 3 distinct phases: elimination for 2 to 6 weeks, systematic reintroduction over 6 to 8 weeks, and then a personalised long-term diet that restricts only the specific foods that trigger your individual symptoms. Monash also recommend retesting your tolerance to problematic FODMAP groups every 3 to 6 months, because tolerance can and does change over time. The goal was always dietary expansion, not permanent restriction. My patient had been on phase 1 for 12 years. That is the equivalent of using a short-term therapeutic protocol as a permanent treatment indefinitely. Now, I want to pause here and acknowledge something important, because I don't want anyone listening who is currently on a low FODMAP diet as part of a treatment protocol to feel alarmed. There are absolutely situations where a low FODMAP approach is clinically appropriate and may extend beyond that standard 2 to 6 week window. SIBO is the most important one to name here. While I'm working with a client on SIBO treatment, a modified low FODMAP approach may well form part of that protocol, but not always. It helps reduce the fermentable substrate available to the bacteria we're targeting, and it supports symptom management during the active treatment window. Depending on the complexity of the case and the treatment approach, that may mean someone is on a low FODMAP diet for longer than 6 weeks. And in that context, that can be entirely appropriate. But even in SIBO treatment, the diet is always time limited and always tied to active treatment. Once treatment is complete, the goal is reintroduction. We want to bring high FODMAP foods back in systematically, diversify the diet again, and rebuild the microbial diversity that supports long-term gut health. The low FODMAP diet in that context is a bridge, not a destination. There are also other conditions where a low FODMAP approach has a short-term therapeutic role: post-infectious gut recovery following gastroenteritis or food poisoning, and endometriosis, where gut symptom overlap is significant. In all of these situations, the same principle applies. It is a time-limited tool used under professional guidance, with reintroduction always as the end goal. And one more thing I want to add from my clinical experience. If someone does need to remain on a low FODMAP diet for a legitimate reason, it doesn't mean fibre has to fall off a cliff. There are low FODMAP foods that can still contribute meaningful fibre to the diet, and with the right professional guidance, maintaining reasonable fibre intake while on a low FODMAP protocol is absolutely achievable. It takes more thought and planning, of course, but it matters enormously for your microbiome and your bowel. And it is something I actively work on with my clients when this situation arises. What I'm describing today is something very different, using it indefinitely without any active treatment, without reintroduction, and without any professional guidance whatsoever. So what actually happens to the gut when someone stays on a low FODMAP diet long term? FODMAPs are the primary food source for many of the most beneficial bacteria in your gut. They are essentially prebiotics. A systematic review of 9 randomized controlled trials found that the low FODMAP diet consistently reduced Bifidobacteria, one of the most important bacterial genera for gut barrier integrity, immune function, and bowel regularity. And broader research has shown that restricting non-digestible carbohydrates has the opposite effect of prebiotic supplementation, causing reductions in beneficial bacteria and shifts consistent with dysbiosis. From a constipation standpoint specifically, and this is where my extensive clinical experience really informs what I'm about to say, prolonged FODMAP restriction consistently reduces the abundance of Bifidobacteria and reduces intake of the prebiotic fiber these bacteria depend on. This has downstream implications for short-chain fatty acid production and bowel function, though the full clinical picture of long-term restriction is still being characterized in the research. Here is the clinical irony. Many people go on a low FODMAP diet because they're bloated and uncomfortable. Symptoms that often include constipation, but staying on it long term without reintroduction actively depletes the very bacteria that produce butyrate, which is the primary fuel for the colonic epithelium and one of the key drivers of peristalsis, that rhythmic, wave-like muscular contraction that moves content through your bowel. You're removing the substrate your colon needs to move, and then wondering why things have ground to a halt. The loss of Faecalibacterium prausnitzii is worth naming specifically here. It is one of the most important butyrate-producing and anti-inflammatory species in the human gut, and its reduction is consistently associated with increased intestinal permeability, dysbiosis, and impaired gut barrier function. This is not a peripheral concern. It sits at the center of long-term gut health. And then there's the trap that so many people fall into. When they finally try to eat normally again, their symptoms come back, and they take that as confirmation that they need to stay restricted forever. But here's what's actually happening. The underlying driver was never investigated or treated, whether that's SIBO, methane overgrowth, microbiome dysbiosis, or MCAS. The low FODMAP diet was managing the symptoms all along, not treating the cause. And in the meantime, the microbiome has been progressively depleted of the populations it needs to handle a diverse diet. The low FODMAP diet manages symptoms, it does not treat root causes, and that distinction matters enormously. Moving on to keto. And again, I want to start by acknowledging what it does well. The ketogenic diet was originally developed for drug-resistant epilepsy and still has meaningful therapeutic application there. Short-term evidence also exists for weight loss, blood sugar regulation, and certain metabolic conditions. The issue is not keto itself, it's keto indefinitely, self-prescribed without any monitoring or professional oversight. A 12-week randomized controlled trial from the University of Bath involving 53 healthy adults found that the ketogenic diet notably decreased Bifidobacteria, beneficial bacteria critical for gut health, which I mentioned before, while a low-sugar diet achieved comparable weight loss without this effect. It is worth noting that this study did not find significant changes in overall microbiome diversity. The primary finding was specifically that reduction in Bifidobacteria. However, when we look at the broader body of research, a 2024 nutrient study and a systematic literature review both found that ketogenic diet adherence is associated with reduced microbiome diversity and significantly reduced levels of butyrate, propionate, and acetate, the short-chain fatty acids that are essential for colonic health and bowel motility. So while the picture varies across studies, the consistent thread is the ketogenic diet depletes the bacteria and the metabolites your gut depends on to function well. The University of Bath researchers also stated directly that the reduction in Bifidobacteria might contribute to significant long-term health consequences, including increased risk of digestive disorders, intestinal infection, and weakened immune function. That is a researcher's stated concern rather than an established fact, but it is grounded in what we know about Bifidobacteria's role in gut health, and it warrants serious consideration. From a constipation perspective, the picture is significant. The extreme carbohydrate restriction of a ketogenic diet results in very little dietary fibre, and ketogenic diet therapy is well documented to cause gastrointestinal side effects, with constipation being particularly common. Both soluble and insoluble fibre drop significantly on a ketogenic diet. The research is clear on this. Insoluble fibre increases fecal mass and accelerates colonic transit through direct mechanical stimulation of the gut mucosa, triggering secretion and peristalsis. Soluble fibre dissolves in water, retaining moisture in the colon and softening stool. When both drop as dramatically as they do on a ketogenic diet, the combined effect on bowel transit is significant and well evidenced. The University of Bath study measured fibre intake at approximately 15 grams per day on the ketogenic diet, roughly half the recommended daily intake in Australia, and well below the 40 grams I recommend to my clients for optimal gut health. Dehydration compounds this further, and there is good clinical evidence for this. During the early phase of a ketogenic diet, urinary water excretion increases due to reduced water retention in the body and reduced insulin concentrations, leading to a loss of fluid and electrolytes, including sodium. Clinical monitoring protocols for ketogenic diet patients specifically flag increased urination and the risk of dehydration as anticipated concerns, with constipation also identified as a complication requiring active management. The most pronounced diuretic effect occurs in the early adaptation phase, but fluid and electrolyte considerations remain relevant for as long as someone is on the diet, and many people simply don't compensate adequately. And butyrate, while important, it is not the only mechanism at play here, and I think it's worth being clear about. The research on constipation and restricted diets point to several converging pathways. Beyond the reduction in butyrate producing bacteria, we have the direct loss of mechanical stimulation from insoluble fibre, the loss of stool softening capacity from soluble fibre, and dehydration. There is also a compelling and growing body of evidence around serotonin. Around 95% of the body's serotonin is produced in the gut, and it is one of the primary drivers of peristaltic contractions. Research published in scientific reports found that gut dysbiosis contributes to chronic constipation through regulation of the serotonin transporter, and more recent work has demonstrated that microbiota-derived butyrate actually promotes serotonin synthesis, establishing a direct molecular pathway from microbial metabolism to gut motility. So, when the microbiome is disrupted by prolonged dietary restriction, it's not just butyrate that falls, serotonin signaling is affected too. And with it, the very mechanism your gut uses to keep things moving. From my experience working with patients over many years, I regularly see people who have been keto for 12 to 18 months presenting with hard, infrequent stools and straining. And when we look at their microbiome, the picture can include significant reductions in Bifidobacteria, depleted butyrate-producing bacteria, reduced short-chain fatty acid production, and sometimes elevated trimethylamine and hydrogen sulfide producing microbes, amongst other parameters. No two reports look identical, but the patterns are often telling. And they are frequently not connecting their diet to their bowel function at all. I also want to touch briefly on the longer-term concern around colorectal cancer risk, and I want to be upfront about the evidence level here. The association between low fibre intake and the colorectal cancer risk comes primarily from prospective cohort and case control studies rather than randomised controlled trials, which simply aren't feasible for this type of long-term dietary question. That said, the precautionary principle matters enormously, especially when someone has been on a very low fibre diet for years. These studies consistently show inverse associations between total fibre intake and colorectal cancer risk, with protective mechanisms including butyrate production from fibre fermentation, which promotes epithelial health, regulates inflammatory responses, and may play a role in cancer cell apoptosis. An umbrella review rated the evidence linking high total fibre intake to reduce colorectal cancer risk as convincing, and global dietary guidelines now advocate a daily intake of at least 25 to 30 grams. We cannot say with certainty that years of low fibre intake causes colorectal cancer, but the weight of evidence consistently points in one direction, and that alone warrants serious consideration. Now, to the most extreme version of dietary restriction currently circulating in wellness spaces, the carnivore diet. Exclusively animal-based, meat, fish, eggs, and some dairy, zero plant foods, and zero fibre normally. It has gained significant social media traction and has passionate advocates. And some people do experience short-term symptom relief, but the most likely explanation for that is the simultaneous elimination of ultra-processed foods, common allergens, and high FODMAP plant foods, not the exclusion of all plant matter per se. A 2026 cross-sectional study of people following a carnivore diet for an average of 36 months found distinct taxonomic changes and profound functional alterations of the gut microbiota, with significant differences in over 300 metabolic pathways, including those related to amino acid degradation, vitamin B synthesis, energy metabolism, gut barrier integrity, and protein fermentation. Enrichment in bacteria associated with hydrogen sulfide production and gut inflammation was a notable finding. Interestingly, the study found that microbiome diversity was not significantly reduced. The researchers noted this was an unexpected finding. However, it is important to note that this study included only 10 carnivore diet followers, so the findings should be interpreted cautiously. And the functional alterations, particularly those affecting gut barrier integrity and protein fermentation pathways, remain a legitimate clinical concern regardless of diversity metrics. A 2025 scoping review published in Nutrients, which reviewed 9 human studies on the carnivore diet, provides perhaps a clearer picture of the long-term risk profile. The review found that while the carnivore diet may offer short-term benefits, including weight reduction and potential improvements in inflammatory markers, it carries substantial risks, including nutrient deficiencies in vitamin C and D, calcium, magnesium, iodine, and dietary fibre, elevated LDL and total cholesterol levels, and significantly reduced intake of health-promoting phytochemicals. The authors concluded that long-term adherence to the carnivore diet cannot be recommended at this time. From a bowel health perspective, the complete removal of dietary fibre dramatically reduces the primary fermentable substrate for butyrate producing bacteria in the colon. Research has shown that butyrate plays a significant role in promoting peristalsis, as we've mentioned, particularly when mechanical stimulation from fibre is low, which is precisely the situation someone on a carnivore diet finds himself in. So the removal of fibre creates a double problem: less mechanical stimulation of the gut wall and reduced butyrate to compensate. Some carnivore advocates report fewer bowel movements and consider this normal. But reduced bowel frequency combined with reduced butyrate availability, enrichment in hydrogen sulfide producing bacteria, and significant functional alterations in gut barrier pathways is not a picture I would consider clinically acceptable long term. When people who have followed the carnivore diet long term try to reintroduce plant foods, they frequently experience significant digestive distress, bloating, pain, changes in bowel habit, and interpret this as confirmation that plants are simply harmful to them. The honest answer is that the evidence on exactly why this happens is still emerging. What we do know from the microbiome research is that prolonged absence of fermentable plant fiber is associated with significant reductions in plant fiber fermenting bacteria, including Bifidobacteria, Rumnococcaceae, and Lactospiraceae. And it is biologically plausible that this depletion contributes to the reintroduction difficulty that is so consistently reported. This is an area where the precautionary principle applies and where proper microbiome assessment, rather than the assumption that restriction must continue, is genuinely important. So what do all three of these diets have in common when used in this way? They all have legitimate short-term therapeutic applications, and they all become problematic when self-prescribed, extended indefinitely, and used without ever investigating and treating the underlying cause of the symptoms in the first place. The pattern is remarkably consistent across all three. Symptom relief leads to confirmation bias. No reintroduction follows. The microbiome changes, reintroduction becomes harder, restriction deepens, and gut function worsens progressively over time. From a bowel health perspective specifically, all three diets progressively reduce fermentable fiber, deplete butyrate-producing bacteria, slow colonic transit, and affect the microbial balance that underpins healthy bowel function. And this is the most important clinical distinction I can offer. Symptom relief is not the same as resolution. A therapeutic diet without a therapeutic endpoint is not a treatment plan. The gut microbiome requires diversity of input to produce diversity of output. Butyrate, short-chain fatty acids, serotonin, immune regulation, and prolonged restriction progressively narrows that capacity in ways that are very difficult to reverse without proper professional support. So what should actually happen instead? If you've been on any restricted diet for more than 3 to 6 months and have not attempted systematic reintroduction, that is the first conversation to have with a qualified practitioner such as myself. And if you feel better on a restricted diet, I want to say something important that is genuinely useful clinical information, but it is the beginning of the investigation, not the end of it. The question is why you feel better, and the answer to that question is what leads to actual resolution. It might be microbiome dysbiosis, it might be mast cell activation syndrome, which can cause broad food reactivity and poor tolerance that goes well beyond a simple food intolerance, or it might be a food intolerance that is very specific and very manageable. But you will not know without proper investigation. If you are currently on a restricted diet, feel better on it, but can't seem to reintroduce foods without your symptoms coming back, please book a consultation with me. This is exactly the kind of work I do. For some time now, I have been helping clients understand why they feel better on the restricted diets, identifying the actual underlying drivers, guiding them through appropriate therapeutic diets for appropriate time frames, and navigating them through reintroduction in a way that is strategic, evidence-based, and genuinely sustainable. You do not have to stay restricted forever. You do not have to white knuckle your way through a bland, limiting diet indefinitely, because nobody has ever properly investigated why your gut reacts the way it does. There is a way through, and I would love to help you find it. Book a consultation with me at lindagripridge.com. I offer telehealth consultations across Australia and internationally, so wherever you are, we can work on this together. The link is in the description below. Please use it. These diets are tools, and like any tool, when used beyond their intended purpose and without professional guidance, they can cause unintended harm, often quietly and progressively, in ways that don't become obvious until the damage is already done. If constipation is part of your picture, whether you're on a restricted diet or not, my Get Things Moving guide is also linked in the description below and is a great place to start. But if you are ready to stop managing symptoms and start getting real answers, book that consultation. The link is there. I'd love to see you in clinic. And if this episode resonated with you, please share it. The people who most need to hear this are often the ones deepest into these diets with no clear way forward. And you might just change someone's life by passing it on. I'll see you in the next episode.